today is a special day because we have organized a program on promotion of regarding promotion of organ donation in this country, uh, and we have invited the all stakeholders who are dealing with this organ retrieval and organ donation, organ retrieval and transplantation. And the today two speakers are Dr. Deepika Amaraweera, consultant anaesthetist at Ampara Hospital. He will be talking about allowed natural death, and then Dr. Suganya Sabaretnam, acting consultant at Kanthale Hospital. She'll be talking about organ donation after brainstem and cardiac death. Before that, Dr. Charit Fernando, consultant vascular surgeon, who is in the committee appointed by the Ministry of Health regarding formulation of the guidelines and formalizing the legal system, and as there are deficiencies in the current system, so he will brief out about the current system which is going on in this country, and of course I'm sure he will talk about few deficiencies what we are having. Anyway, within with very soon we are going to formalize and we are going to make this program nationwide, and we are going to invite all the including the public to get involved with this so-called trust of the organ donation, and especially the disease organ donation. Okay, over to you, Dr. Charit Fernando. You can speak about the system.
Thank you, Dr. Ramya. I was asked to give this impromptu 5 minutes talk just as an introduction to what she just referred about a panel that has been appointed in the Ministry of Health regarding streamlining the disease donor program. First of all, what I can say is that there are about 750 to 1,000 brain dead patients in Sri Lanka, and at Kandy we have done 30 disease donor transplants, and I don't know the exact figures. That is last year in 2017, and in probably Maligavat, the only unit, and Sri Jawadanapura, the two units that do brain dead disease donor renal transplants, maybe 20. So we have done 50 disease donor renal transplants in this country in 2017, whereas we could have easily done, of that 1,000 to 750, say half are not suitable donors, then still we could have done 600 to 700 disease donor renal transplants, and there are thousands of patients. I mean, at least 400-500 people are dying of renal end-stage renal disease. There are about 500,000 diagnosed CKD patients, so about 400-500 are dying each year in this country. So it's a colossal waste of organs, and I've been sort of, to be honestly, very unpopular with the anesthetists because I've been raking up this issue of not diagnosing brain death, and about the whole process of the consenting process. There are major flaws in the Tissue Act, but I don't think I can go into that in 5 minutes. I just want to say that the cooperation of the anesthetist is the most important thing, without which nothing could happen and proceed. Okay, thank you very much.
Is new and the system is new. This streamlining thing. Sorry for the inconvenience.
Hospital, Ampara. And do you have some idea about this topic, allow natural death? I don't know, many meanings. Different people will have many meanings. This is something last 2 years I was in UK for my foreign training. This is where I was trained. The Canterbury, the beautiful area, very interesting and with a lot of tourist attractions. And side of the view, you can see the Canterbury Cathedral. It's a very beautiful place. And this is the Canterbury Hospital, where I worked for my second training period. And it's mainly a vascular and urology center, and it has a 9-bedded ICU and also day surgery care unit. This is where I was in my first year. This is Queen Elizabeth and Queen Mother Hospital in Margate. It has also a 9-bedded ICU, and there were a lot of Sri Lankan consultants, 3 or 4 Sri Lankan consultants, and our trainees. So I'm gradually coming to my topic. You may be familiar with these logos. Definitely it should be something related to the heart. One is Resuscitation Council UK. Second thing, European Resuscitation Council. So, you know, we are giving cardiopulmonary resuscitation for several patients, usually maybe in the wards, maybe in the emergency department, or maybe in the ICUs, commonly ICUs, maybe sometimes very rarely theaters. So this is a record kept by a UK doctor in his diary, end of the day, after giving resuscitation for several cardiac arrest. So ultimately he started like that. What does this CPR achieve? Break his sternum, break his ribs, crack beneath your hands, push, 100 times per minute, feel for pulse. Oh, you got it. Okay, leave him to die again. What is his name? I don't know. Okay, go ahead. Airway checked, breathing checked, circulation checked. What happened next? Log on to the computer. Oh my God, hypertension, diabetes, ischemic heart disease, and dementia. What I have done? End of the line. Okay, now coming to my presentation with little bit of introduction. In our ICU cares, we are giving different mode of treatments, maybe ventilation, vasopressors, inotropes, dialysis, or different modes of advanced treatment. But even not in the Asian countries, but also in the UK or European countries, it has been estimated that 27% of the management we have done in the ICU is futile or inappropriate. There may be several reasons, maybe poor communication or diagnostic uncertainty or defensive practice and cultural and religious belief, etc. This defensive practice and cultural and regional beliefs are applicable to us, I think. And when come to the cardiopulmonary resuscitation, out of hospital cardiac arrest, we know the survival rate is very poor. It's around 5%. If it happened in the hospital, we can have little bit more results, up to 15%. It's still very low. When coming to the cardiopulmonary resuscitation, can we give 100 out of 100? No, definitely not. At least 50? No, it is not. Very hardly we can give maximum 25% out of 100. But in our society, people have unrealistic beliefs, unrealistic hopes on top of cardiopulmonary resuscitation. They think it will save the life of each and everybody and each and every time, but it does not. So decision of CPR is based on balance between the benefits and the burden. So we should understand the cardiac arrest is the final stage of dying, and CPR not be successful for everybody. If the patient is in the extreme of age, 70s, 80s and 100s, or is having multiple medical problems, ischemic heart disease, cardiomyopathies, hypertension and its complications, stroke, renal failure. So the successfulness of CPR may be becoming poor and poor. And if CPR is successful, then spontaneous circulation will return. But it is a benefit for some people, but some people it is not a benefit. Unnecessary we are increasing the burden for the family, country, society, and everybody. Previously, I have shown some logos. You may familiar with this logo, and this is the logo of the do not attempt resuscitation. And there are some definitions for the do not attempt resuscitation. I have mentioned something very simple definition. It is a legal order written. It should be a legal order. It should be documented, either in the hospital or on a legal form, to withhold cardiopulmonary resuscitation or advanced cardiac life support in respect of the wishes of the patient in case their heart were to stop. Okay, there are different terminologies. Every part of the world, different terminologies. Even in the one country, there are between hospitals there are different terminologies. The correct one is DNA CPR. Do not attempt cardiopulmonary resuscitation. Or we can, when we communicate with somebody, we can say DNR. Do not attempt resuscitation. But it is not a very good term, because the resuscitation, it may be a fluid resuscitation or some other form of resuscitation. It has not specified about the cardiopulmonary resuscitation. So DNR still we can use and allow dignified death. These terms we can use when we take the consent for the DNR from the patient, because these two terms are very popular, because it explains something we are going to do. In other terms, it explains something we are not going to do. And DNAR, do not attempt resuscitation. NFR, not for resuscitation. NTBR, not to be resuscitated. Not for the triple two. That means 222 means there's a call for the resuscitation team. So not for 222 means not for resuscitation. And red form, that's the color of the DNR form. Okay. So when we do our clinical practice, some patients we are directly giving cardiopulmonary resuscitation or do not attempt resuscitation. But some people, when managing the patient, they give some cardiac compressions that is not hard enough to compress the heart, not adequate rate, or that like half CPR, quarter CPR, or 3/4 CPR. There's nothing called half CPR, quarter CPR, or 3/4 CR. If you want to resuscitate the patient, give complete cardiopulmonary resuscitation. If you are not going to resuscitate, don't resuscitate. In between, no options. This is something the DNR was very common in UK. I checked some laws related to DNR decision in England and Wales. There are some laws, Mental Capacity Act 2005, Patient Article 8, that is about human rights. It explains like that law does not entitle patient to demand treatment from doctors, and doctors are ultimate deciders of what treatments are offered to the patient. Any treatment offered to the patient must be clinically appropriate. If it is not appropriate, we are not going to offer. If the patient lacks capacity, it must be in the patient's best interest for the treatment to be administered. A doctor cannot be compelled by the court to attempt CPR if he or she does not consider it appropriate. This is a very famous court case couple of years back in UK. Court case Mrs. Janet Tracy. This incident happened some Cambridge hospitals. You can see this patient, and she's 63 years old, a very active patient, a care home manager. 2011 February, she diagnosed to have lung malignancy, and estimated life expectancy was 9 months. Same month, she had a RTA, she suffered with cervical spine fracture. She was treated in the neurocritical care unit and she was ventilated. As usual, she got pulmonary sepsis and weaning was failed. Because of poor mobility and new problems, life expectancy came down, and patient could communicate with writing, and she indicated her willingness for full active treatment. Then question of resuscitation was raised. So intensive care issued a do not attempt resuscitation order, and she was successfully weaned from the ventilator. Then patient's daughter became aware of the DNA CPR, and she was reportedly horrified, and DNA CPR was withdrawn. Patient was competent and refused the discussion of the resuscitation, and next month she was deteriorated, and second DNR was issued with the agreement of the family, and she died same month. This patient's husband was David Tracy, claim against the hospital, and the reason he mentioned is it failed to consult Ms. Tracy or family members. It failed to notify her of the decision of impose the notice. It failed to offer her second opinion. It failed to make DNR policy available to her. So this is the judge gave some statement, and you need to focus only red color areas. For the patient with capacity, there should be open dialogue and shared decision making between the patient and professionals, unless the patient declines any such discussions. The patient should be invited to discuss the risk and benefit of CPR in order to reach an agreement decision on whether or not it should be attempted. I should emphasize that the claimant in the present case is not complaining about the substantive decision to withhold CPR. It is about aspects of the procedure which led to the making of the decision. So this is the decision given by the judge against the hospital. I would therefore grant a declaration against the trust that it violated the Ms. Tracy's Article 8 right to respect the private life in failing to involve her in the process of which led to the first. There was no problem with the DNR decision. The problem was there was poor communication. They haven't discussed with the DNR decision with the patient or relatives. That was the problem. There was no problem with the DNR decision. And DNR decision can be very difficult. I think you may be familiar with this guy. This is, who is this? Yes. This guy, very popular professor, scientist in Cambridge hospitals, and 1960s, I think, when he was 21 of age, diagnosed to have slowly progressive motor neuron disease. That time his life expectancy was 2 years, but he died few months back, 2018. So if there's thing called DNR in those days, he will not be resuscitated, but he was there up to last few months. So DNR decision is very difficult. Sometimes our decisions may be incorrect. Sometimes it may be correct. And benefit and futility remains subjective and difficult to define. And other thing is, we should not take any blanket decisions. That means we are not going to resuscitate everybody with obstructive cardiomyopathies or COPD with home oxygen or multi-organ failure. We can't take such blanket decision. The decision should be highly individualized. There are the indications for DNR, very few. If the CPR is unlikely to be successful, we can think about the DNR. And if the CPR is successful, if the clinical outcome is poor, still it is indicated. Like patient with diabetes, hypertension, peripheral vascular disease, bilateral amputations, very poor. he can't maintain his hygiene even. So no much indications, there are few indications. In UK, there are some leaflets to educate the patient about the DNR decision, and there are some centers to educate the DNR decision. So there are common questions legally binding advanced decision or last will. What if I change my mind? You can change your decision. Your health team will help you to take decision. How is DNR different from the advanced decision? The DNR is written by the doctor. The advanced decision is written by the patient. And DNR decision only apply for the cardiopulmonary resuscitation at the time of cardiac arrest. But in advanced decision, you can include cardiac resuscitation or ICU admissions, hospital admissions, invasive procedures. You can mention everything in the advanced decision. But in the DNR, you should mention only regarding the cardiopulmonary resuscitation. When will the DNR be issued? Your healthcare team feels that CPR is unlikely to be successful. Your healthcare team feels that it is unclear whether or not CPR would be successful, and following a discussion with them, you decide that you don't want CPR. CPR would be successful, but clinical outcome is poor. How is my treatment after DNR decision? Rest of the management will be continued. And what if I am unable to decide for myself? You can nominate a lasting power of attorney. Who else I can talk about this? There are counselors, independent advocacy services, patient advice and license services, patient support services, and spiritual care. Every hospital has some small church or temple like thing. You can go and discuss. When come to the DNR decision, there's thing called capacity. What does it mean by capacity? The capacity is understand information relevant to the decision and retain information, and can use or weight information and communicate with their decision. That is capacity, the component of the capacity. Okay, the people who worked in UK or some European countries, you may be familiar with this form. This is the DNR form, and some in UK they commonly say this is red form. Some patients, like our BHTs, we say it is care plan. Some patients have very big care plans. If there's a DNR form, we can very easily identify because of this color. What are the components of the red form? Patient's name, address, date of birth, NHS number like our BHT number, and the time you have to mention. Then does the patient have capacity to make the decision CPR? Then you need to write something. If there's no capacity, you are aware of valid decision refusing CPR. If patient is having some advanced decision, you need to mention it. And if has the patient appointed a welfare or attorney to take a decision. Summary of main medical problems and reasons why CPR is not appropriate. Communicate summary with patients and welfare attorney. If not communicated, what are the reasons? Summary of the communication with the relatives and friends. Name of members contributing for the decision, and healthcare professional. We have to mention who are the healthcare professional, maybe a consultant, registrar, theatre nurse. You have to mention everything and their details, their numbers and full name. We have to mention. Regarding the DNR guidance, there are some statements made by the BMA, British Medical Association, and the Royal College of Nursing and Resuscitation Council UK. This is a combined statement about the DNR. It's recently updated. There's a framework how we come to a decision not to attempt resuscitation. So you will not be able to read, but I will go one by one. In the decision making framework, the first question we need to ask is is cardiac arrest is a clear possibility for the patient. If the cardiac arrest is a possibility, we are going to discuss about the DNR. If it is not a possibility, we can't go and ask about the resuscitation. So I have mentioned two patients. Patient 1, 70 years old, diabetes, ischemic heart disease, ejection fraction 15%, came with a cardiogenic shock. Is he going to have a cardiac arrest in near future? It's more likely. So we can discuss about the DNR with this patient. Second patient, 60 years old, SA1 patient, RTA, multiple hip fractures, I2 admission due to desaturation. Maybe desaturation may be due to pain, and managed with oxygen and pain relief with epidural. Are we going to discuss the DNR with this patient? No, he's not going to have cardiac arrest in near future. So unlike, sometimes we need to discuss the DNR with second patient. If he's voluntarily come and ask us, doctor, I saw my mother and father was resuscitated in the ICU, very bad. I was shocked after looking at that incident. Can I ask for a DNR? Then we can initiate the discussion. Okay, this is the DNR. You can go to the community and you can ask from the GP, and you can, before that you have to write the advance decision, then you have to inform to the GP, then GP will write the community DNR. So the first question is the cardiac arrest is a clear possibility, now no problem. Second sentence is there a realistic chance CPR to be successful? Okay, now there's a possibility of cardiac arrest, and is there a realistic chance CPR to be successful? So if no, so that means it's not going to be successful. That's an indication for DNR. So we can write DNR, inform to the patient, explain everything to the patients and relatives, and if there's a power of attorney, we can discuss if the patient is not having the capacity, and if the patient is not agree with our decision, we can ask patient to go and have a second opinion from somebody. If there are realistic chance CPR to be successful, if yes, now there's a possibility of cardiac arrest, now there's chance CPR going to be successful. Check whether patient had advanced decision refusing CPR. If patient has successful cardiac arrest, we can resuscitate, we know, but he has taken advance regarding the CPR. If no, talk to relatives to understand the best interest, and if yes, discuss with the patient. Now the patient has good capacity. The next question comes, is the patient willing to discuss his or her wishes regarding the CPR? If no, respect and document her wishes, contact relatives to guide her. If yes, patient must be involved in CPR and DNR. We write DNR, but after discharge patient 15%, but next echocardiogram says it is 35 or 40. Now it has been improved. So we need to review, and no blanket decision. Decision should. This is a real patient I got during my UK appointment. It's a 58-year-old lady, relatively young. Maybe she's a teacher. Past medical history only hypertension. Presented with chest pain. Aortic dissection was diagnosed. Airway breathe in, she's on oxygen, spontaneously breathe in, respiratory rate 22, saturation good, cardiovascular hypertensive on GTN infusion, GCS 15, she's nicely talking. Though our Canterbury hospital is a vascular center, they are not doing any cardiothoracic interventions. So we need to transfer the patients to London. Plan to transfer the patient with blue lights to cardiothoracic unit in London. It's a 1-hour journey, accompanied by an ambulance crew and a nurse. Nurse went to adjust the GT and infusion. No doctors. Explain the management to the patient before going. GT and infusion and morphine. DNR is issued. Are you happy with this DNR decision? Are you happy? Hands up who are happy with this DNR decision. Hands up those who are unhappy with this decision. Yeah. With first glance we say this is inappropriate, but this DNR decision was only valid for the transfer. From Canterbury to London, if patient is collapsed, what's the point of resuscitation in the ambulance? In the aortic with the patient with aortic dissection. Once the patient reached the London, automatically this DNR decision is cancelled. So you need to understand DNR decision can be issued for a short time. Sometimes some patients it's a lifelong management, but time to time we are issued it for a short time. Only this ICU admission, only this hospital admission, only for the transfer. You need to understand. This is another case. 42-year-old female, SA1, road traffic accident, severe head injury, neurosurgical opinion taken, conservative management, no compatible with life, poor outcome, DNR was issued. Relatives strongly request CPR. They are not agree with the DNR. What we are going to do? Management, senior experienced clinician with good communication skills need to involve in this clinical scenario. We need to explain everything in the very sensitive way. If further conflicts regarding the DNR decision, we can ask relatives to go and take the second opinion. Because we are not going to offer anything, we think it is not appropriate. So about DNR discussions, sometimes we need to discuss with the patient, sometimes we need to discuss with the relatives. Offer as much as information and be open and honest. This is not applicable only to the CPR, it is applicable to every management in the medicine. The language should be clear and combination of verbal, written, diagrams and everything. We can use anything. The information should be accurate and we have to cross question whether a patient understood or not. We can explain something and we can ask if the patient has some knowledge about that understand. So if patient has not understand, we can explain again and again. If we can't, we can ask somebody who is very experienced with good language skills to involve in this business. And we need to spend adequate time in very good room or place. Usually in UK ICUs there are separate rooms for discussions with patients and relatives, and we need to record each and everything we discuss. So earlier I showed a first page of a BMA, the guideline, British Medical Association, but it has not highly focused on anesthesia. So we have AAGBI guidelines for DNR. This is highly focused on anesthesia. There are some recommendations. Management of a patient with DNR in the perioperative period should be focused on what resuscitative measures will be embarked on rather than what will not be done. So we more towards the resuscitation, and patient with DNR should be referred early to the anesthetist and surgeon. If patient is having a DNR in the ward, if he is scheduled to come to the theatre, you need to inform to the anesthetist and surgeon a little bit early, because they need to spend some time on this matter, because we need to review the DNR. So we can easily say if patient is having DNR, we are not going to resuscitate, but when it comes to the theatre, we need to review the DNR, because you may remember at the beginning of the presentation I said the in-hospital cardiac arrest, the survival is maybe 15%. But it is estimated that in the theatre, if there's a cardiac arrest, the successfulness is more than 90%. So we need to review. So the indication we issued the DNR earlier is not applicable not applicable now. So because CPR successfulness is much more higher. So other thing is, in the theatre we intubate the patient, give oxygen, ventilate. So it's a part of resuscitation. Usually for a cardiopulmonary resuscitation we maintain airway, oxygen, some minor drops. So we have if we are giving GA for a patient, we have started something we commonly use with cardiopulmonary resuscitation. We have started something already. So we need to continue with cardiac compressions and some adrenaline doses, defibrillation. So that's why we need to preview the DNR decision. And after the DNR review, we can come to we can take three options, whether to DNR is to be continued or discontinued or modified. So the DNR modified means, that means we can take decision, okay, if the patient is having some ventricular fibrillation or ventricular tachycardia, shockable rhythm, we are going to resuscitate. If asystole or PEA, so we are not going to resuscitate, like we can take some modifications. Agreed DNR management options should be documented in the care plan. Care plan means our BST. Like DNR management options should be communicated with the other staff. You know, once the patient comes to the theater in the UK, there's a thing called team brief. Everybody is there, is nurse, surgeon, and anesthetist. Everybody introduce themselves and they communicate about, okay, for this patient I'm going to intubate, I'm going to ventilate, I need this for the intubation, I need this. The surgeon said I'm going to do laparoscopically, I want this. So there are some team brief. At the team brief, we can explain the DNR decision, we have modified this decision, so we can mention everything to the other clinical staff. So when at the time of review of the DNR decision, there are hierarchy. If the patient has capacity, if the patient wants to continue the DNR decision, we allow to continue the DNR decision. If patient has no capacity, then we have to look for the power of attorney or some relatives or next of kin. If nobody is there, we can take the decision. Clinician can take the decision. If anesthetist is not happy with the DNR management options, arrange suitably qualified colleague to take over the role, because there are some highly doctors with good skills and good communication skills. They can take this job and they will continue. And if there's a doubt, every hospital has some legal department. We can look for help. In emergency, doctor will take decision depending on the available information. That is very clear. DNR is once the patient go to the ward, once the patient goes to the ward, the DNR is restarted. So we have modified, but it is only applicable to the perioperative period. Once the patient go to the ward, the now usual DNR applicable. Another case. This is a 74-year-old male, diabetes, ischemic heart disease. He is having internal cardiac defibrillator. He is having prostate malignancy with liver metastasis. Life expectancy less than 1 year. He is in terminal care. He is having DNR. So if there's a ICD, if there's a shockable rhythm, it delivers some shocks. So it's type of cardiac resuscitation. So if the patient is having DNR, are we going to take this ICD out? This problem arises. We can't do, because ICD removal and DNR is two different things. Okay, you need to understand. And DNR decision and ICD deactivation should be discussed separately, but you can discuss same time, or you can discuss in two different times. And DNR can trigger the discussion of ICD deactivation, and DNR does not automatically warrant ICD deactivation. And there are some guidelines regarding the ICD deactivation, but I'm not going to discuss it now. Another case, 65-year-old male, SA3, diabetes, hypertension, COPD, multiple hospital admissions due to urine retention, has advanced decision, no CPR, he's having DNR. Presented with nifedipine overdose. This is a suicide attempt, because with recurrent urine retentions, he may be depressed. He has taken a lot of nifedipine for a commit suicide. A&E, he had a cardiac arrest. What to do? How many going to resuscitate? Hands up, who are going to resuscitate? Hands up, those who are not going to resuscitate. Madam, you are going to support the suicide. Yeah. if the patient is coming with some suicide attempts, we need to resuscitate or the patient is having DNR, because otherwise we are helping for suicide. 82-year-old female presented with neck of femur fracture, multiple medical problems. She is allergic for penicillin. In UK, there are some bands around the hand. If it is red, that means patient is allergic for something. Patient is having DNR decision. Came to the trauma theater for DHS, had spinal with TCI propofol for sedation. Anaesthetist gave a dose of tazocin. Tazocin is a type of penicillin. BP unrecordable, diagnosed to have severe anaphylaxis. Cardiac arrest, what to do? Those hands up, who's going to resuscitate? Yeah, this is not a natural death. This is iatrogenic death. We need to resuscitate this patient, though he's having DNR. 76-year-old male, multiple medical problems, DNR in situ, presented with stridor. Tracheostomy done, now patient in the ENT ward. Cardiac arrest, found to be dislodged tracheostomy. What we are going to do? CPR road, no CPR. Hands up, who is going to resuscitate? Yes, we need to resuscitate. This is a rapidly reversible problem. So if the patient with DNR coming with choke in or dislodged ET tube, tracheostomy, we can resuscitate. There are some interventions usual cardiologists doing. Has some inherent some procedures. It initiates some cardiac arrest, like angiogram, pacemaker insertions. So if the patient is having DNR, some cardiologists say if something happened, because of this procedure we'll get cardiac arrest, so we want to suspend this DNR for a short time. So you can ask from the patient. DNR usage by country, most of the European countries it is acceptable. Italy it is not acceptable. United Arab Emirates have laws forcing healthcare team to do CPR. Sri Lanka I don't know. And this is summary. This is end of my presentation.
Okay, good afternoon, everyone. It has been a long day already. Just some more slides to go. So I'm going to speak on organ donation after brainstem and cardiac death. So, not working. Okay, so we are just going to see a little bit about the history, the organs for donation, some statistics, the pathophysiology and confirmation of brainstem death, and the management of donation after brainstem and cardiac death, and what we can do to improve our donation rates. So a little bit about the history. The transplant started around the 1900s. In 1906, Jabulay started a renal transplant. He used animal organs for 2 patients, which we know without any doubt they didn't survive. In 1936, Voronoi tried the renal transplant utilizing a kidney from a cardiac dead patient. Again, the recipient didn't survive because the donation was taken after the organ was retrieved 6 hours after the cardiac death. In 1956, the first time there was a successful transplantation. Merrill and his colleagues did the transplant. It was the donor was the identical twin of the recipient, and both were well. 1963, the first liver transplant was done, but the recipient didn't do well by Starzl. 1964, lung transplant by Hardy. 1967, we all know the famous Christian Bernard's cardiac transplant. And in 1981, the first heart-lung transplant by Reitz and colleagues. So, initially the donations came from the cardiac dead and the brainstem dead patients, but the criteria were not established that much. In 1950, there was a great improvement in the critical care, and mechanical ventilation was improving with time. So in 1959, after observing cases in their neurological intensive care patient, Mollarat and Gulan described a state, the state they described as a state beyond coma, where the patient didn't have any spontaneous breathing, had a irreversible loss of consciousness, and there was no brainstem reflexes. So in 1968, after several journal articles, the Harvard Medical School published the first Harvard criteria about the brainstem death. In 1976, the UK took it over. They did a conference of medical royal colleges, and they published the first guidance on the diagnosis of brainstem death in UK. 1979, they added a memorandum which equated brain death with the death of the whole person. What happened in Sri Lanka? So in 1987, we had the first Human Tissues Act transplant, the Act number 48 of the 1987. Unfortunately, we didn't do any further revisions. So currently discussions are going on. We will, I think we'll get the revisions in the near future. So in 2010, there was a general circular 1/37 given out by the Ministry of Health, which was on the implementation of National Organ Donor Program for deceased donor organ transplantation. When were the first cadaveric transplants done in Sri Lanka? The renal transplant was done in 1995. I might be wrong. I got these figures from paper articles, and the 1995 was from the surgical journal. Liver transplant happened the first time in 2010. Lung transplant in 2011. Pancreas happened in 2016. The heart and the lower limb transplant were done last year, the first time in Sri Lanka. Okay. So, what are the organs that are available for donation to us after a patient has passed away? So, solid organs, heart, lung, the 2 kidneys, the liver, pancreas, small bowel, and in some parts of England, they take the facial tissue as well. So if you take the tissue transplant, you can take out cornea, sclera, the heart valve, bone, tendons, the menisci and the skin. So ideally one donor can contribute to 8 solid organs being transplanted into the recipients. But if we take the world over, but I am talking about the UK figures, the average organ that are donated per donor is 3.8 after a brainstem death and 2.8 after a cardiac death. So what are the contraindications for organ donation? So if the patient who is going to be deceased is age more than 85, any cancer with evidence of spread outside the affected organ within the 3 years of donation, any cancer that's melanoma apart from the stage 1, choriocarcinoma, active hematological malignancies, those are absolute contraindication. And also in probable or possible cases of spongiform encephalopathies like the prion diseases, any other neurodegenerative diseases are an absolute contraindication. And untreated systemic infections, tuberculosis, active and untreated, HIV disease, and the patients who have hepatitis B. Hepatitis B, only the surface antigen positive patients are contraindicated. If they have a co-antibody positive, still we can go ahead with transplantation. If they are hepatitis C, it's not absolute contraindication, because if your recipient is hepatitis C positive, you can still go ahead with the organ transplant. So what are the contraindications per organ? If your the donor has acute hepatitis, cirrhosis or portal venous thrombosis, it is a contraindication to donate the liver, but still the other organs can continue to be donated. What are the contraindications for kidney donation? If your patient has a CKD, on long-term dialysis, any known case of renal malignancy, any previous kidney transplant, more than 6 months. What about pancreas? So if your patient had insulin dependent diabetes or any history of pancreatic malignancy, this is an absolute contraindication to donate the pancreas. Heart, if your recipient is in urgent need of heart, then if the age is more than 65, it is absolute contraindication. If it is not urgent, then you go through the history. So if they have documented coronary artery disease, median stenotomy, any ejection fraction less than 30, massive inotropic or pressor support, those are contraindicated for heart donation. If we see the lung, if it is after cardiac death, if the donor age is more than 65, if it is a brainstem dead patient, if the donor age is more than 70, or previous intrathoracic malignancies, any significant chronic destructive or suppurative lung disease, or any chest X-ray evidence of major pulmonary consolidation. Those are the contraindications. Let's see some statistics. So I did my overseas training in UK, so I'm used to the UK statistics. This is the data taken from the Organ Donation and Transplant Activity Report, which was published in March 2018. If you see, there is a gradual increase in donors after brainstem and cardiac death, and it reached the highest in both cases and in total in the last year, which is a significant achievement. So in last year, if we take the UK population, it's around 65 million, 3 times the amount of Sri Lankan population. UK deaths, there was 600,000 deaths, half of it happened in hospital. Out of those, after taking out of the contraindications, there were potential donors who were around the number of 7,281. After excluding them, the eligible donors were 6,000 odd. Only 3,329 donation requests were made. Out of that, after speaking to the family, 2,233 donors were consented. From them, the actual donors were 1,574. From the organs we took, they have transplanted 4,000 odd patients, and the organs that were transplanted were 4,473. What about Sri Lanka? Unfortunately, we don't have a national registry. So I had to call my colleagues from each of the hospital mentioned here. So these numbers may not be accurate. These are taken from the theatre statistics and statistics from the transplant coordinators. From 2017 and 2018 up to now, in total, we have done 96 kidney transplants. We have done 25 liver transplant, 2 heart and pancreas transplant, and 1 lower limb transplant. So according to the interview given by the vascular surgeons to the Sunday Times in February 2018, apparently there were 39 deceased donors in 2017, and there were 72 kidneys and 11 liver cadaveric transplants. Okay, so let's see what happens after a brainstem death in brief. So in brainstem death, there is increase in intracranial pressure. To maintain the cerebral perfusion, the blood pressure increases. With the blood pressure increase, there is more and more increase in intracranial pressure, which leads to pontine ischemia. There is an adrenergic storm, which leads to hypertension, and there's a Cushing reflex, which causes bradycardia. So due to all these catecholamines, there is increase in the pulmonary vasoconstriction leading to hypertension, increase in the systemic vascular resistance. Because of the increase in afterload and direct action of the catecholamine, there is myocardial ischemia. And with further cerebral edema, further increase in the ICP, there is herniation through the foramen magnum, and the ischemia spreads to the spinal cord. So there is no more sympathetic stimulation, so it leads to vasodilatation and impaired cardiac output. So pituitary is affected. So the anterior and the posterior pituitary ischemia leads to diabetes insipidus, decrease in ACTH and TSH secretions, leads to hypothalamic dysfunction, which contributes partly to the hypothermia, and also the vasodilatation and less muscular activity also contribute to the hypothermia. And because of all these cytokines and inflammatory markers, there is derangement of coagulation. So these are the common derangements. Hypotension and diabetes insipidus are very common. There can be DIC, cardiac arrhythmias, pulmonary edema, and metabolic acidosis, which are commonly reported. So how do we diagnose the brainstem death? So UK, the latest publication is the 2008 Code of Diagnosis. I think our circular was basically based on that. So according to the circular sent out by the Ministry of Health, so there should be 2 medical officers, anesthesia or intensive care, from the treatment team should do the brainstem death testing. They should have been medical practitioners 5 years or more. One of them should have been preferably a specialist, and none of them involved with the transplantation or treating the recipient or designated officer who is authorizing the removal. And we should not do the brainstem testing until 6 hours after the onset of coma, or if there had been a return of spontaneous circulation, we should wait for 24 hours. And the brainstem death testing is done twice. After the second time, we should alert the transplant team coordinator, but the time of death is given at the end of the first testing. Okay, this is the brainstem death testing sent out by our Ministry of Health. Most of us have done it once or more. so I'm not going to describe it. So after we have confirmed the brainstem death testing, alerting the transplant coordinator, we should think about whether to request for an inquest or not. Depending on the circumstances, we should do one according to the Code of Criminal Procedure. And the transplant team will review the patient, look for any contraindication, and then they will discuss it with the family to get the consent. When I read through our Tissue Transplant Act, it doesn't say which next of kin has the authority to give the consent. So I had to borrow this order from the Human Tissue Act 2004, which is prevalent in England, Wales and the Northern Ireland. So this is the order of qualifying relationship there. So spouse or partner, parent or child, then comes the brother or sister, grandparent or grandchild, niece or nephew, then come the step relationship, stepfather or stepmother, half brother or sister, or friend of long standing even can give the consent there. So when they have discussed, the transplant team coordinator, after discussing with the family, after getting the consent, when they decide to proceed with the organ retrieval, they will inform the police post formally, and then the police post will inform to the inquirer into the sudden death or the magistrate of the relevant jurisdiction, and also the JMO will have to be informed in writing about the retrieval. The JMO will give an opinion how to proceed. He or she might be present in the theatre when the organ retrieval is going on to observe and record findings. And after the organ retrieval, they might do an autopsy, and with their report, they will attach the retrieval surgeon's report to the formal autopsy report. So this is the Sri Lankan procedure according to the General Circular sent out by the Ministry of Health in 2010. So how should we manage a brainstem dead patient? So I contacted our intensivist. I don't think we have guidelines per se in Sri Lanka. So we are following most of the time the UK guidelines. This is by the Blood and Transplant Authority in UK. So we'll take each system on how to resuscitate. Now this is for in view of organ retrieval and to as much as possible to get the organ which is well perfused. So in the cardiovascular system, most of our brainstem dead donor patients will be hypovolemic. So we have to assess the fluid state, give them more fluids. What kind of fluids to give? So according to the Intensive Care Society's guidelines and also the American guidelines, it is better to give crystalloids rather than colloids. And in crystalloid, you can use the Hartmann solution, or you can use the 0.9% saline. They don't give any preference over one another. Hetastarch, they say it might lead to graft issues after transplantation, so it's better to avoid any starches. And if your patient doesn't have cardiac output monitoring in place, it would be ideal to initiate one cardiac output monitoring or the flow monitoring to guide your fluid resuscitation. Sometimes in the initial stages, because of this catecholamine stage, your patient might be running a MAP more than 95. That's a bit transient, but still it can cause damage to the heart if you are planning to retrieve it. So in these cases, you should think of using a short-acting antihypertensive. Esmolol would be your choice. If we don't have it, GTN or sodium nitroprusside, we can use it. What are our hemodynamic goals in management? So aiming for a MAP of 60 to 80, the preload as mentioned, the heart rate, rhythm, cardiac output, the systemic vascular resistance index, and the mixed venous saturation. These are the goals given by the Intensive Care Society. Yes, and if our patient doesn't have any arterial line in place, it would be better to put arterial line onto the left side, the radial or the brachial artery. This is because of the order in which the vessels are clamped during the organ retrieval. If we are going to put a new CVP or a pulmonary artery catheter, it would be better to go for the right side, internal jugular or the subclavian. And also most of these patients will be hypotensive. So after getting normovolumic, if they are still hypotensive, we should start some vasopressors. So if we go through the journals about brainstem dead patients and the organs retrieved from them, they find that if you use noradrenaline and adrenaline in these patients, this causes more damage to the heart. It causes pulmonary vasculature leakage, leading to more neurogenic pulmonary edema, making the retrieved lung and the heart not so suitable to transplant. So they suggest to avoid both, start vasopressin, start at 0.5, targeting your hemodynamic goals, you gradually increase it up to 4 units per hour. And if you need an inotrope, it would be better to introduce dopamine or dobutamine. That is, they say, because of the immunomodulatory properties in both of them. What about the respiratory system? After our apneic test, most of our lungs will be collapsed at the alveoli level. So we should perform lung recruitment maneuvers and continue with our low volume lung protective ventilation, targeting the tidal volumes 4 to 8 mils per kg, and also the PEEP set around 5 to 10. We should continue with the chest physiotherapy regularly, suctioning as per protocol, make sure your head elevation is still maintained, and endotracheal cuff pressure monitoring is appropriate. If we are planning to retrieve the lung from this patient, we should do bronchoscopy, do bronchoalveolar lavage, and toileting for therapeutic purposes. What are our goals? To keep the PaO2 10 kilopascals or more with as much as minimal oxygen as possible, FiO2 0.4 or less. And the PCO2 targets are 5 to 6.5 kilopascals or higher as long as your pH is less than 7.25. What about the endocrine system? The diabetes insipidus is very common. So we should, as much as possible, try to keep the sodium less than 150. This is the Intensive Care Society UK, but according to the US guidelines, they aim to maintain less than 155. This is very important if you are planning to donate the liver. So you can use NG water, or if your urine output is more than maintain your urine output between 0.5 to 2 mils per kg per hour. But if there is evidence of diabetes insipidus, you should promptly start vasopressin with or without the desmopressin puffs. And we should start or continue the insulin infusion to keep the blood sugar levels between 4 to 10. With all this, we should make sure we give methylprednisolone. So the dose should be 15 milligram per kilogram, maximum of 1 gram. This helps very much to retrieve as much as organs as possible, because it will contribute to the cortisol level, it will decrease the inflammation, and it will decrease the vasopressor support that's required. The temperature should be kept between 36 to 37.5 with active warming whenever possible. And we should continue with our TED stockings, the pneumatic compression devices, continue or prescribe low molecular weight heparin, continue hourly observation according to the guidelines, perform a 12 lead ECG, perform a post-recruitment chest x-ray. And also we should make sure we should send out all the blood investigation as requested by the transplant coordinator Usually it's all the basic biochemical tests, the tissue typing, and also the virology. What about the thyroxine? So in the initial period, they were talking about triple therapies, utilizing vasopressin, methylprednisolone, and giving thyroxine as well. But nowadays, giving thyroxine is a bit of a questionable area. So hypothyroidism is known to associate with depleted energy stores, shift from aerobic to anaerobic metabolism, reduced cardiac function, but it's not consistently reported after brainstem death. So they have done a study where they prospectively analyzed 37 brainstem dead patients, and they found that the thyroid hormone treatment did not improve hemodynamic status or cardiac function. So it depends on your institution. If you have a guidelines to give thyroxine, you can give, but it is not recommended by the Intensive Care Society. So arrhythmias are very common. Bradyarrhythmias are resistant to anticholinergics, because remember, atropine acts on the vagal nerve. So it would require adrenaline or isoprenaline to maintain the heart rate. For tachyarrhythmias, it is suggested to use amiodarone. So we have confirmed the brainstem death. We have got the consent, sorted out the legal problems. We have taken this donor to the theatre. What should we do there? It should be a senior anesthetist who should be there with a prior experience if possible. There might be hemodynamic instabilities. We should control that with vasopressors. If the blood pressure shoots up, maybe anesthetic drugs and vasodilators. Make sure we paralyze the patient. Remember, only the brainstem has been lost. The spinal reflexes are still there, and the patient might move the limbs. This might be very traumatic to your theatre staff who do not understand the brainstem death testing, and would lead to a media outcry. Okay, so you would be required to assist with the blood sampling. This vascular surgeons will ask you to give heparin just before clamping the aorta, or maybe before the organ harvest. You might be required to give more antibiotics, further steroids, and if we are planning to retrieve the lungs, you would be asked to give inflation breaths and to pull up the endotracheal tube before they staple the trachea. This process of organ retrieval will be involved in blood loss, so you might be required to transfuse blood and blood products. What about donation after cardiac death? In Sri Lanka, we haven't still come to the proper guidelines on end of life care yet. So it's coming. It will come in the near future, hopefully with the changes in the Tissue Transplant Act. So in 1995, they classified categories 1 to 5 on donation after the cardiac death. So 1 is the patient who was dead on arrival to the hospital. 2 was a patient whom we have tried to resuscitate but were unsuccessful. 3 is the patient whom we have initiated the end of life care and waiting to pass away. And 4 is a patient whom we have confirmed the brainstem death, and we are in the process of sorting out things, and the patient has a cardiac arrest. 5 is a patient who was in the ICU, didn't have any plans, unfortunately developed a cardiac arrest. So there is a controlled type of cardiac death and an uncontrolled type. So categories 3 and 4 are generally suggested to be controlled death, because we are prepared, we are sort of ready to go for organ retrieval. And in the latest journal articles, they are talking about cardiac arrest while on ECMO. So I would say that is also a control type of cardiac death, because we can control the ECMO. So how to proceed with a donation after cardiac death? So this is how we did things in UK during my overseas training. So first of all, we should see the patient. We should decide the futility of the treatment. So when there is no overall benefit in continuing with the care, the decision of end of life care should be taken by a consultant, preferably in discussion with another doctor. There should be two doctors who should confirm that there is futility in continuing with this care. Then after speaking to the family, informing about them, making them sure that they understand about withdrawal of care, we should inform the SNOT. The SNOT is the specialty nurse who is for organ donation. So with their present, we should seek for consent for organ donation. The SNOT would do the consenting for the organ donation, and if we have the consent, we have to continue the management of withdrawal of life sustaining treatment while we are getting ready to withdraw. So if the patient is on inotropes, it would be appropriate to continue with the inotropes till the time we get the results back, till we get things sorted. So we can do managements as long as it's not harming the patient. So UK doesn't allow heparinization before cardiac death. UK doesn't allow femoral cannulation before the death. So these are the things which should be done after that. So look out for clinical criteria in donation after cardiac death. Look out if they have any absolute contraindications. And then we do the withdrawal of life sustaining treatment. So in the institution I was trained, we do not do withdrawals in the ICU. We take the patient and the relatives down to the anesthetic room, which nobody else will enter. The doctor from the ITU will accompany the patient there, continue to monitor after the withdrawal. The relatives will be there, continuing to support the patient, and we'll be looking out for features of asystole. If our patient is already on invasive line monitoring, we'll be looking out for asystole on the invasive monitoring. If not, we'll look for asystole on the ECG monitoring. And after there is no cardiac output, no spontaneous respiration, irrecoverable loss of consciousness, after 5 minutes we'll confirm the cardiac death. And the relatives will be given some time to proceed before the patient is taken to the theatre inside. So the family should be very well warned. When we have withdrawn treatment, sometimes the patient might pass away quickly, sometimes they don't pass away even after 4 hours. So you should prepare mentally the family members what might happen. So in the instance where your patient passes away within the stipulated time, you would go ahead, let the relatives mourn, and then take the patient as quickly as possible inside to the theatre, where your organ retrieval team is ready to go ahead with the retrieval. But in case your patient doesn't pass away within the stipulated time, the donation will be stood down, and the relatives will be informed, and the patient will be taken back to a quiet area to allow them to pass away in comfort. It might be back to the ICU, or it might be back to an isolation room or a quiet place in a ward. So how will we know whether the cardiac death is going to happen quickly or not. So in 2003, the University of Wisconsin published a criteria. Have a look at that. So they predicted asystole depending on these criteria after withdrawing life supporting therapy. So they assessed it after 10 minutes after disconnecting from mechanical ventilation. You do the scoring system. If the score is between 8 to 12, your patient has a higher probability of continuing with the respiratory effort. 13 to 18, moderate probability. 19 to 24, low probability. So it had an overall accuracy of 88.4%. So what is this stipulated time period we are talking about? It all boils down to the warm ischemia time. So the warm ischemia time starts from where the systolic blood pressure drops below 50 millimeter mercury or the saturation drops below 70%. From that time period onwards till the cold perfusion is started is the warm ischemia time. What is the allowable time for liver? It's 30 minutes in an optimal donor. In a suboptimal donor, it might be even 20 minutes. What about the pancreas? Same goes for it, 30 minutes. Lungs survive a bit better, 60 minutes. Kidneys are the best. So kidneys are in worldwide are the most commonly transplanted organ after cardiac death. We can give up to 2 hours, and in some institution, depending on your protocol, you might give another 2 hours depending on your organ donor. So how to increase the donation rates? So the UK has the opt-in option, where in Australia and New Zealand as well, where you the general public go to the organ donation registry online, you register yourself, or if you don't want to donate, you register your refusal. So that is taken as a consent in case you go on to have a brainstem death. That is taken as your consent. In case you didn't register with the organ donation registry, you might have made an advance directive, or you might have talked to your family members about your wish to donate. So that is also a way of consenting. So Sri Lanka, we don't have a national registry, but still when you apply for your driving license, you can let them know. So if you are an organ donor, they will put that up on your driving license. So that's the card which you can print it out after registering with the organ donation in UK. What about other countries? So in USA, there's a thing called required request. So in US, there's a statutory requirement for the doctor to make proper inquiries as the possibility of organ donation before disconnecting from the ventilator if your patient is brainstem dead. Some countries have legislation to increase the donation rates. Like in Israel, they give preferential access to transplantation to individuals who have joined the state donor register and to the relatives of actual deceased donor. So if I say I have registered for organ donation and then I am in need of organ donation because one of my organ has failed, then I will be given priority. So there is no free rider. People who don't want to donate don't get the priority, or if you want to donate, your relatives get the priority. That might improve the rates. So if you have a look at the European map, this is the data from the Council of European Committee on Organ Transplant. Have a look at Spain and France. Their rates are much higher. Spain 43.8 per million of the population. How did they do that? So they have the system of opt-out. So most of the European countries, including Spain, and also since 2015, Wales has also introduced it. So you are presumed to give consent to organ donation unless you have registered your refuser. So it's the other way. You have to opt out if you don't want to donate. So in addition, Spain and Wales have a soft approach. Your relatives can refuse donation on your behalf. But in Austria, they have the hard approach. If you have not registered your refusal, your relatives can't refuse for organ retrieval. Directed donation is where the deceased donor would have wished his organs, his or her organs to be given to a family member. So this can take place provided that you follow some criteria. The donation must be otherwise unconditional. Only one organ which is directed, the other is unconditional, given to the recipients waiting on your national registry. And if there is an unrelated recipient who is on a super urgent waiting list, they will take priority over your relative. The related recipient must be on a UK transplant waiting list, not anywhere else, and a suitable match for the particular organ and a close friend or a relative of the deceased. So what can we do in Sri Lanka? We might have to change the law, which might come in the near future. We can adapt to opt out, because many people, during a survey done by the doctors, they found out that people wanted to donate after brainstem death, or they had the idea that they wanted to donate but never registered themselves on the organ donation registry. So if you do the opt out, so if they don't want to, they can opt out. The rest of them will go on to be organ donors. And maybe we can come up with donation after cardiac death in Sri Lanka to improve our organs available for transplantation. And we have to do educational campaigns. Why is that? So if you have a look at the reasons why the family did not support organ donation in UK, according to the last year's report, the primary reasons given by the family were that the patient has previously expressed a wish not to donate. Family were not sure whether the patient would have agreed to donate, did not believe in donation, was against their religious or cultural beliefs. The family was divided against the decision, or they thought the patient has suffered enough and they didn't want any more surgeries to the body. And some of them thought, if we go ahead with donation, the time spent with your deceased relative will be restricted. And some of them had difficulties understanding in the brainstem death testing, and they felt the process will take too long for their religious beliefs and furthermore. So this is an interesting thing I found out in the organ donation report. Even after consenting the family, everything done, still the donation did not proceed in some cases, where the family changed their mind after giving the consent halfway through, or there were legal contraindications to take, or the organs were deemed unsuitable by the recipient centers, or after opening up the patient on surgical inspection, or the patient there was a prolonged warm ischemia time, or while doing everything the patient went into a cardiac arrest, or there was general instability, or not enough logistic issues, like there were not enough retrieval teams to go ahead and retrieve organs, and positive virology, or the family placed conditions on donation. So if we take the NHS organ donation registry, there are 24.9 million people on the opt-in register as of the March 2018. So that's almost 40% of the population. I'm not sure how many of us have registered with the Sri Lankan thing. Around 500,000 of them had registered opted out, and further 86 had appointed representative registration, where somebody else will make the decision for them if it comes down to it. Almost 50% of the deceased organ donors from the last year were on the opt-in registry, and 50% of the registration came through the driver and vehicle licensing agency. And it was interesting to note that there were 101 families who overruled their loved ones' known decision to be an organ donor. This is where we need educational campaigns. So the key message is, when appropriate, please undertake brainstem death testing early as possible. Inform your transplant coordinator. I'm only putting up the NHSL number. I don't know the others, but depending on the center that's near to you, you can obviously contact your regional place through the exchange. For NHSL, the transplant coordinator number is displayed with Dr. Harendra's permission. It's that number 375 from any Mobitel SIM, and manage the patient according to the protocol. Not everyone wants to be an organ donor, but definitely we don't want to be a poor organ donor. So we should keep the organ perfusion as maximum as possible, and look out for the changes in the Transplant Act. Any questions? I'm sure everyone